Okay. So the summary of the problem was that, trauma can occur at any age, and the clinic that I work at works with serious and persistent mental illness. So as I was researching it, I found that approximately 40 to 70% of adults with serious and persistent mental illness experienced at least one traumatic event outside of the mental health care system. And there's approximately a 50% of individuals that have experienced it within the mental health care system. My organization was trying to implement trauma informed care, so I kind of built off of theirs to advance the application of it to develop a trauma aware, educated, and responsive workforce. My practice setting, we are a community certified community behavioral health center located on the eastern shore of Maryland. I work specifically for this capstone within the integrated outpatient clinic with um, the direct care staff and clinical staff. There are, I think, 10 different programs across 3 or 4 different counties, at least, in our agency. Um, so I used an evidence-informed intervention instead of an evidence-based intervention. I chose to use the SAMHSA Treatment Improvement Protocol, Tip 57. It comes in a book format, so I was able to translate that into a in-person 3-part training series to be delivered to the staff instead of asking everybody to read the book in various sections of it. SAMHSA had in this book had defined a trauma-informed care as a strengths-based perspective that's grounded in the understanding of and responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both the providers and the survivors, and in creating opportunities for survivors to rebuild a sense of control and empowerment. For implementation science, I also chose to use intervention mapping. It is a common process model to help design multi-level health promotion interventions in a clinical setting. I then used the theory of change, the COM-B, to examine what those core components are for that will either facilitate or hinder behavior change. From there, I used the theoretical domains framework to identify at micro level changes to help with the individual levels. And then I used the CFER to look at the intervention level and the setting barriers and facilitators. From there, I went and used the behavioral change techniques to identify actual strategies of what I could do within my capstone project to try to change behaviors, and then the ERIC strategies for looking at the intervention in the context. These are the categories of my barriers. The memory, attention, and decision process was a very big barrier to prioritize. We've had a lot of staff turnover during the process, so there was not only are we short-staffed and picking up extra responsibilities, staff were also, some staff had been there almost 30 years and they're used to doing something a certain way, so they were not certain if, one, they would be able to remember the material that they learned, and two, they would remember how to change a process that they were going um, to be doing differently. The design, quality, and packaging was a very large barrier, and I changed that through the intervention by making it an interactive training. And the last barrier of leadership engagement, I had added during implementation when I knew I had leadership support initially. There ended up being a lot of conflicting or competing projects for attention that I needed to find other ways to be able to engage them to help prioritize like this project as well as everything else. So my facilitators was that the intervention is developed by SAMHSA, and with the organization becoming a CCBHC, they were required to implement trauma-informed care, and there is that advantage of using SAMHSA guides or processes that they get automatically approved. Then the culture was also a very big facilitator in my office. The culture, the overall environment we work in really does promote learning where staff can ask for input for one another, opinions, suggestions, and they're already comfortable with giving and receiving feedback to one another. So the implementation strategies I used were prompts and cues to help give not only paper copies of prompts and cues, but also digital ones and integrate them into the electronic health record system, promoting adaptability of helping bridge the gap of how do I take the information from the training and SAMHSA's tip guide, and how do I adapt that into each specific job role within the integrated outpatient clinic. Identifying preparing champions was added on to assist in working with supervisors and gaining their support, and then being able to also model and the behavior changes and the shifts in perspective. These are my 6 research questions that I had related to implementation. The first 2 were trying to look at what the reach was and working with different staff. And then I had a question to examine each of the implementation strategies. These were my original research questions. And because I really, really like data and collected a lot of data during the bivariate analysis, I ended up having an additional 35 questions, and I will not be going through all of them tonight. And these were my research questions to see if the training increased their knowledge of trauma-informed care, increased their having positive attitudes towards trauma-informed care, as well as if there was an increase in the use of trauma-informed practices. And through these 3 research questions, I was able to add another 46 questions to look at. So for my measures, I used the REAIM framework, really focusing on reach, effectiveness, adoption, and implementation. Due to time constraints in the project, I was not able to look at the maintenance of it. I had a pre-test survey, which was the participants quality survey, which allowed me to collect data demographic information. For the attendance, I had participants identify a code word so I can collect attendance, because there were staff in attendance at the training and at ongoing meetings that were not participating in my study or my capstone project, and I wanted to be able to differentiate who's participating and who's not. We had the implementation leadership scale, which had a pre-test and post-test. There was a supervisor versions for them to evaluate the perception of themselves, and then there's a staff version for them to evaluate the perception of the supervisor. Then I had adapted the knowledge, attitudes, and practice scales to be more specific to mine. And then the last measure was a post-test only measure to really examine the 4 implementation strategies. So some key outcomes for the how many staff participated, I would say that there was a 90% participation rate. There were 23 staff members that were direct care or clinical staff, and I was one of them. So I had 20 out of 22 presenting, because I don't think I could have participated myself. And I saw how many of them attended by number of job sessions and number of learning collaboratives. I did have one participant that did not attend either of the 2 job adoption sessions and none of the learning collaborative sessions. That was likely due to them either being sick or off. It just so happened to fall that way. For the prompts and cues, that 73% of them reported strongly agreed that the handouts were really helpful in remembering what the principles of trauma-informed care was. And for me, that was very important to help remember that, because that is the core principles of what so much surrounds around, everything surrounds around, and we try to bring it back to that. And for the job adoption session, there were some significant negative correlations between the number of years people worked in their job role and how they understood how the trauma-informed approach related to their job role. And then also between their years worked in job role and feeling capable of doing it. So because it was a negative correlation, it was that the fewer number of years in your job meant you had a greater understanding of how that approach relates to your job, and you felt more capable of doing it. For the learning collaborative sessions, we transformed one of our huddle meetings that we have every Wednesday into a learning collaborative, and 94% of participants said that they either strongly agreed that using that time as a learning collaborative was beneficial to their professional development. 60% said they would like to continue it. And here I'd also found a significant positive correlation that the benefits of the learning collaborative sessions went up with the number of years that you had been in your job roles, so that the individuals that were in their job roles longer found it more helpful. And then for preparing strategic leadership, there were no differences between how staff viewed leadership and how leadership viewed themselves at pre-test, but at post-test, there were significant differences. the staff's perception of overall strategic leadership went up almost twice as much, creating a significant gap. Um, and the scale had divided up strategic leadership as being proactive leaders, knowledgeable leaders, perseverant leaders, and supportive leaders. The proactive, knowledgeable, and perseverant also went up significantly, and there were no differences in supportive leadership. And that is incredibly important because how staff or how supportive and strategic leadership is can really impact how implementation efforts are going to be. If they are more supportive and helpful and positive to it, there's going to be like a better foundation for having changes happen. And then for the intervention, so there were increases in overall knowledge, however, it was not significant. There was one item within the knowledge set of questions that did show significant improvements that really showed that staff were moving away from the pathology mindset of what is wrong with you towards the resilience mindset of what has happened to you, what have you been through, what have you experienced, and that you might be having a normal reaction to an abnormal situation. As far as the attitudes did trend towards significance at 0.08, which I thought was pretty awesome because I had a very small sample size. And there were also significant improvements, statistically significant improvements that trauma-informed care is essential to working with clients that receive care from us. And I had also seen among clinical staff that routinely screening for trauma had increased from 46 to 80%. Okay. Key insights and takeaway. The Learning Collaborative, I do believe it addressed the actual barrier of our current training system that had self-paced training models that were seen as inadequate. And the majority of the staff said that that was beneficial to their learning and support and development. And promoting adaptability, and more than half of the staff also agreed that they understood like how that approach related to their job role, whereas initially they weren't really sure how that related to them in their various roles, and nearly all staff felt capable of using it. It is important, or it is important that they are holding a positive view to it, because if they have a positive view towards trauma-informed care, they are going to be more likely to use it with clients. The next steps is this project can inform future implementation projects at the organization, because oftentimes the training resources are dedicated to new staff that might be beneficial to assess what their knowledge, skills, and abilities are with the new practice they're going to be doing, as well as possibly looking into establishing a learning collaborative for people that have been in their jobs for a longer period of time to help them shift and change their practices. The second next step is that it's important to continue to prepare champions to support the implementation efforts, because even though they view themselves as less strategic or less overall strategic leaderships, the staff perceptions increase significantly, and how supervisors can positively or negatively impact the capacity for change.